All right, we are back with our last session. We just heard an incredible surgical session with international experts debating. And so now we're going to sort of shift focuses, not from technical surgical issues, but some more challenging GI cases that perhaps could also interest many of the surgeons who are watching. So we will have Dr. Barr and Dr. Pastricha present some cases, and curious to see the debate here.
Hi, so thank you. And thank you for allowing me to participate in this challenging GI cases session. We have a lot of cases. We may not go through all of them. So without further ado, our first patient.
I'm sorry to interrupt. Before I forget, I almost forgot. I need to also introduce our other co-panelists.
Sorry.
We also have Dr. Levitsky, who's a gastroenterologist at Newton Wellesley, and Dr. Kalmet, who are also both gastroenterologists at Newton Wellesley, who will help us moderate this session. Sorry for that.
No worries. So for our patient, who's a 44-year-old female, she presents with dysphagia. You can see her past medical history. I just want to point out that she is obese and she uses opiates because of her spinal stenosis and low back pain. And her dysphagia has been going on for 15 years. It started with solid food dysphagia. It's now liquid food. It's both to liquids. And she has no regurgitation. She has some odonophagia. Her weight is stable, as we can imagine. And she has heartburn that is controlled with PPI. So the first thing she does is an EGD, which was normal. And she also has a almost normal barium swallow. She has a normal caliber esophagus with complete emptying of the barium, but she does have a holdup of her 13-millimeter barium tablets. Her gastric emptying scintigraphy is normal. And so she goes on to have a manometry, which is not normal. It shows type 3 achalasia. As you can see, she has an IRP of 34, which means her LES does not relax. And she has 100% spastic contractions. She does not have normal peristalsis. Because of this slight discrepancy between the barium swallow and her manometry, she undergoes endoflip, which is also abnormal. She has low indices of low distensibility indices and retrograde contractions, which are the pathological ones. She does not have her normal antegrade contractions, which we see in healthy controls. We repeat the barium swallow, this time in a timed fashion because her last one was a year ago. And we see that she has, maybe it's hard to see, she has a 2-centimeter barium column at 5 minutes. So it's not grossly abnormal. So to summarize and start this discussion, this is a 44-year-old patient with opiate use and obesity, type 3 achalasia per manometry, but her barium swallow does not show the classic achalasia picture. And she has an abnormal endoflip. So I'd like to raise a few questions to our panel about what do you think, what would you say about the etiology, and also what would be your management for this patient?
So, one question I would like to ask is if the patient was on opiates when the manometry was done and when the endoflip was done as well.
The answers to both questions is yes. She was on opiates and she did not stop them.
I think that's such a critical point. I mean, yesterday at the keynote address, Peter Karelis had mentioned the impact of opiates. And I think especially with the type 3 with emptying, this is a tough problem because there are also studies that show that if you withdraw the opiates, the manometric abnormality essentially goes away. The challenge, though, is are you going to be able to withdraw opiates? She's been taking this long term for chronic back pain. It may be impossible to get rid of the opiates.
Spoiler alert, she was uninterested in stopping the opiates.
Yeah. I mean, and this is the one that we had the discussion at the end of yesterday's session, which, what would you do? I mean, I think that this could be one of those rare situations where you can give Botox and see if that helps. I almost never give Botox to a patient, but chronic opiates with emptying, type 3, I would be hesitant about offering anything more But sometimes if they start to progress, dysphagia gets worse. This may be somebody who may end up getting therapy, and I think the only therapy that would be reasonable would be a poem.
The other thing to note is that the opioid, so it's exactly as you said, the type 3 achalasia is very commonly seen in patients who have esophageal dysfunction and opioid use. The other second most common, or even slightly more, is EGJ outflow. But it's important to know, I think, that the response, there's another study that showed that it's a kind of a dose response. So if she's either willing in some ways to come down on the dose or even switch to a different weak or moderate opioid like tramadol. There have been studies comparing dysphagia and type 3 achalasia in patients who are on opioids versus tramadol. I mean, that would be kind of another bargaining chip, because that could, in and of itself, improve her symptoms. And I agree with Dr. Krishnan that this might be someone you could give Botox to, even if it's just to buy you time as you're sorting out some of these management questions with the patient and the primary care doctor.
One other way to try to differentiate if her achalasia is secondary to opiates or idiopathic is also seeing what the response is to pharmacologic interventions during manometry. So there's one study where if you give amyl nitrate to patients undergoing manometry, normally you'll see a relaxation of the LES, and then in the cases of opiate use, after about 30 seconds, the contraction comes back, but it's a weak contraction. And whereas with an idiopathic achalasia, it tends to be a more abrupt, very dramatic response. And there's also another intervention, which is with cholecystokinin, which in idiopathic achalasia causes almost like a spastic contraction of the distal esophagus, EGJ, in two phases, which you don't see as prominent with opiate-induced. And if you do this to differentiate, that can also serve as a bargaining chip to tell a patient this is due to achalasia, or this is actually idiopathic and perhaps not related to the opiates.
Another thing that came up in the discussion so far is this distinction between EGJ outflow obstruction sometimes is not so easy to make with type 3 achalasia. On the slide that was presented, when I'm looking at this one isolated contraction on the Chicago class 3.0 manometry, I almost see a hint of peristaltic movement on that slide. And so this would be a patient that I would probably also like to see a rapid drink challenge, multiple rapid swallows that were not done on a Chicago class 3.0 protocol. It's not clear to me if this is actually truly type 3 achalasia on this one picture, or if it's actually a EGJ outflow obstruction case.
I think that's a great point. But I also, we struggle with these patients because they have longstanding dysphagia. Now they have something that they're going to hold their hat to and say, oh, we have achalasia now. We have a manometry that proves it. I need therapy, and then they're going to go around looking for a Heller or pneumatic or a poem. But I think kind of tying in some of the other talks that we've had, this is the perfect patient, I think, for Botox and dietary modification. I mean, if you look at it, they have no dilatation of their esophagus. They don't have spastic contractions. They don't have pain as a primary component. The tablet getting stuck, it is what it is. But I think Botox is going to be the way to go. And that'll buy you time, as Dr. Pastrica mentioned, to kind of do some of these additional testings that were recommended.
Okay, so that's true. I think you may be the person who actually saw that patient, and as she was referred to Botox, which she has done, but we don't have follow-up. So I'll have to, maybe mid-2020 will be 2022 will be when we'll know what happened to her. But that was great discussion. And in the interest of time, I'll continue to my next case, which is actually two patients that have some similarities and some differences. The first one is a 67-year-old male. He complains of nocturnal regurgitation and solid food dysphagia. This is mostly when eating steaks or bread. He also has some heartburn and sore throat. And on EGD, we found an esophageal diverticulum that has a suspected stricture distal to it. He also underwent a manometry. This is all in our outside hospital. And this showed an EGJOO, an esophagogastric junction outflow obstruction. He had an IRP of 17 with normal peristalsis. He didn't have failed peristalsis, just like Dr. Levitsky discussed in our last case. This patient had normal peristalsis in most of his swallows, and he had incomplete bolus clearance in 90% of his swallows. So we know now that this is not enough to constitute an EGJOO. And also, and he does have dysphagia, but he was sent to a barium swallow, which confirmed the diverticulum, which was epiphrenic. It was a few centimeters above the LES, and there was normal esophageal emptying. In that outside hospital, he was referred to a Heller's myotomy with a diverticulectomy, but the operation was aborted because they couldn't mobilize the diverticulum into the abdomen, and they referred him to thoracic surgery. Another patient is a 71-year-old female who presents with dysphagia. She's had dysphagia for 8 years, both to solids and liquids. She eats slowly, and this improves with drinking hot drinks. She has occasional regurgitation, some heartburn, and no chest pain. Her weight is stable. So she undergoes an EGD, which shows a diverticulum in the mid-esophagus in a different location. And she also undergoes barium swallow, which shows us our mid-esophageal diverticulum, but also shows a non-emptying esophagus that's slightly wide, and in a barium column that goes as high as the proximal esophagus, and the barium tablet also gets stuck. So she also has a manometry done that shows achalasia with incomplete bolus clearance, but she also has a chest CT because this is a mid-esophageal diverticulum, and her chest CT shows atelectasis or scarring of the left upper lobe with calcified lymph nodes just adjacent to their diverticulum that could be compatible with old TB. And this raises, of course, the etiology of a traction diverticulum. This could be this for this diverticulum. So to summarize, these are two patients with diverticula, but they are different. They both have dysphagia, but the first patient has an epiphrenic diverticulum and an EGJOO that according to the Chicago 3. And this third patient has a mid-esophageal diverticulum. Again, she also has obstructive LES mechanisms. She has type 2 achalasia, but she also has evidence of old TB. So what I would like to ask the panel is what are your thoughts about LES-directed therapy in each of these patients? And would you treat the diverticula for everyone, and how would you do that?
Well, I mean, these are two very interesting cases. I mean, a tale of two diverticula. And the second patient, the one who had the epiphrenic diverticula, I thought the workup was perfect. Oftentimes, manometry is not performed, and it's important to kind of determine, is this a pulsion diverticulum or a diverticulum secondary to true EGJ outflow obstruction? And at least in what you presented, it does look like it could be more related to EGJ outflow obstruction. His symptoms, though, are not consistent. It's mainly regurgitation, which is probably pooling. So I actually would agree that I would refer that to a thoracic surgeon for myotomy plus removal of the diverticulum. I'm curious what the rest of the group, though, thinks.
I would agree with that. If you, with the patient number 2, if you don't address the EGJ outflow obstruction and just remove the diverticulum, it's likely that you may just develop a recurrence in that area. And you should really address both. The symptoms sound like they're more due to the diverticulum than the EGJ outflow obstruction, mainly with regurgitation. But I feel like you need to address both. The patient number 3 is interesting because with the mid-esophageal diverticula, some of them can be pulsion, and those are, and you can see that with achalasia, but then there's also evidence of some traction component with the old TB, and with the traction type diverticula, these rarely cause any symptoms in the mid-esophagus. So I wonder how much of the symptoms of patient number 3 are due to the diverticula and not to the dysphagia and not to the achalasia itself. So I may be inclined to maybe not be as aggressive with the diverticulum and treat just the achalasia at that point.
Might be a little bit on patient too. From my standpoint, I think this is maybe a good example of what changed for EGG outflow obstruction from Chicago classification 3 to Chicago classification 4, meaning previously it was mainly a manometric diagnosis, and now with version 4, not only do you need manometry findings consistent with EGG outflow obstruction, but you need a clinical sort of correlate, which is his dysphagia, which he has, but you support that with additional testing, whether that's a barium swallow or an endoflip thereafter, if there's something equivocal. And in his case, with the barium swallow, and I didn't see Dr. Barr if his was done with a 13 millimeter tablet, but if 13 millimeter tablet was not getting stuck at the EGJ, at the esophageal gastric junction, I'm not sure that the issue is a manometric problem there. It sounded like there was an implication earlier in your slides that there maybe was a stricture seen on EGD. I don't know if that was addressed, but it might be more of a mechanical issue. So I'm not sure that I would, in the absence of other supporting data on the barium swallow, would do EGJ-directed therapy, short of addressing first the diverticulum. But he might be somebody who would be a candidate for endoflip if after treating the diverticulum his symptoms persist, then it would be worth pursuing further.
Absolutely. I absolutely agree. Another question I could raise to the panel is, usually we look for for some way to prove that there is actual obstruction. Now, an epiphrenic diverticulum is in itself usually associated with LES obstruction. So would you consider this a proof of the EGJ00 and that would tip you over to treating this patient's LES?
Yeah, I mean, that's kind of how I approached it. I mean, I think that if it's a real epiphrenic diverticulum, that sort of is your clue that the issue is sort of some degree of outflow obstruction. Now, you may get more pooling into it, and it is kind of interesting that the barium study sort of went through, but, presumably if there's not a traction diverticulum or a source of a traction diverticulum in that area, I don't know if I would feel comfortable referring just for the diverticulotomy or diverticulectomy without doing EGJ-directed therapy.
Okay, so I think we may have time for one more case, a short one. This is an LPR case, which was discussed in the surgical session in the morning. So I'd like to just jump to just another achalasia patient. She's a 31-year-old patient, and she had achalasia diagnosed at the age of 15 years ago. And then she underwent Heller's myotomy with fundoplication, and she felt fine for many years and was lost to follow-up. When she returns age 31, she has dysphagia with every meal, daily regurgitation, occasional chest pain, and heartburn that is alleviated with PPI. Now, an interesting thing she says is that she usually has food coming up, especially when she lies down on her left side. And on EGD, where they found lots of fluid and food in her esophagus, and they seem to think that there were there was a narrowing just proximal to the LES. When another EGD was attempted, it had to be canceled because of food remnants all through the esophagus. It wasn't done with anesthesia, so there was worry of aspiration. And this is her time barium esophagram. This is 1 minute, 2 minutes, and 5 minutes. And we can see that she has a dilated esophagus and what we call a sink trap deformity. And you can see that all of her esophagus is on the right. So I imagine that when she lies on her left, everything gets pushed up. And that's why she feels the regurgitations lying down on her left. And Her manometry shows what could be compatible with type 1 achalasia. And I was wondering about management. Would you, considering this, this barium swallow, do anything? Would you think of doing LES targeted therapy, or because this is such a, it's a type of sigmoid esophagus, so the sink trap deformity is associated with trouble emptying the esophagus, and would you even consider a more radical esophagectomy for this patient?
This is a tough problem. This is a real tough problem. Nir, did you say the IRP was normal? I thought it was 20.
No, her IRP was 24. Her IRP was 24, and she had what looked like type 1 achalasia.
Okay, so there is a elevated IRP then in this patient, in addition to the other findings of achalasia post-treatment. So there's some evidence, presumably, that there's perhaps an incomplete myotomy, and there was a narrowing at the EGJ. Now, the tough part with the narrowing is after a fundo or after a Heller and a partial fundoplication, there's always this question: is that wrap too tight? Did it become kinked in some way? Is it in some way sort of twisting the EGJ, or is it truly some fibers that remain to be cut? I mean, at some point in time, this is where that amyl nitrate, I think, is helpful. But to be perfectly honest, this person is 34 and is going to need some degree of therapy. And as we heard about earlier today, I mean, esophagectomy as a salvage in a young patient is an incredibly morbid procedure. So I think whatever you can do to avoid that morbidity. And with a dilated esophagus, you can do POEM. But I think with that wrap, this may be a good situation to do, refer it to one of our surgeons, have them undo the wrap, do intraoperative endoflip, redo the myotomy, maybe even a thoracic approach, and redo the wrap and try to get whatever straightening you can. But this is going to be a problem.
Yeah, I think this is like the classic case for intraoperative endoflip, because like you said, Kumar, I think, we don't know if it is incomplete myotomy versus the wrap that's causing the issue. And I think it will be great to take it down, see how it looks before and after, and then if need be, if it's an incomplete myotomy, then you can also at the same time do a completion myotomy at the same time.
Question for Ben, Fernando, would you guys consider doing a pneumatic?
Probably not in this one. I think the surgical approach makes sense, although I would say that with a sigmoid appearing esophagus, just looking at the picture, it seems like it measures at least 5 centimeters, which is a bad prognostic indicator. Even if you do address the LES, it's just the aperistaltic component and the configuration of the esophagus makes it such that even if you do address the LES component, you may still have significant symptoms after that, especially in a 34-year-old. Pneumatic, the other issue is that with that sigmoid configuration, it's going to be difficult to get a good angle at that, I feel. One interesting approach may be to do esoflip in this one, where you can get a good positioning and stretch that open a little bit. But I have a feeling that even if you do a surgical revision, optimize the LES, she probably will end up needing some very likely esophagectomy sometime in the future, maybe 10 years down the road. It's not a good prognosis.
Yeah, the sigmoid sink trap deformity really would give me pause to do pneumatic dilatation for her.
Yeah, I do think though that something at the LES is needed. I wouldn't be so hesitant, only because it's probably not going to work, but it will probably buy time until the inevitable when they see Charu, and he's got to do something robotic, is my guess. Charu, any thought about laparoscopic or robotic for a redo in this situation?
Yeah, that's a great question. You know, redo surgeries are never easy, as we heard Dr. Morse talking about today in the lecture. The advantage of the robot in redo surgery, and I don't know how it will be measured because, you know, Dr. Bonin mentioned today that the studies have not shown significant difference between robotic and laparoscopic. So I do both. The subjective advantage of actually seeing the planes when you're doing redo surgeries it's a big advantage robotically, and the wristed movements in these kind of cases are important. And so if there is a choice, I would, you know, book this case robotically just for that reason. It's not that we haven't done this laparoscopy. I've done it laparoscopically in many cases as well, but just that advantage is there robotically in this case. And to your former point, I think the longer we can sort of push the inevitable, like everyone has said, because of the sigmoid shape of the esophagus that's already chronically dilated, the better it is in this very young patient. So yeah.
Okay. So I'd like to thank Dr. Krishnan, Dr. Levitsky, Dr. Kalmet, Dr. Pasrisha, and of course, Dr. Paranjip. And I think this is it.
Great. We'll come back with questions.